Thank you, man, and thank you, the organizers, to inviting me, and thank to the last two of the three speakers for introducing mucosal immune response and intranasal administration. Expanding on that concept, I'd like to highlight the benefits of mucosal immunity in general. On the left, you see how it basically mimics natural infection, which is the port of entry for many pathogens, including influenza. I will show you some data at the end of the talk that shows that mucosal immunity actually correlates with protection in wild-type infection and intranasal administration of attenuated strains, but is not a correlate when you vaccinate parenterally. And mucosal immunity could be viewed as the first line of defense. We usually view infection as getting sick or having a systemic immune response. You can have isolated mucosal immune responses and not see the pathogen systemically. It is faster, broader, and better in naive individuals. I think that the point that was raised with H5 in the last conversation is that it's a surprise that you would get a high immune response to H5 with this replication defective mutant. One explanation could be that anything that you put in mucosally does better if you're naive. So you might not see that with parenteral vaccination, but you may see that with mucosal vaccine administration. Additional benefits of our product in particular is thermostability and nasal self-administration, nasal/self-administration. This is a benefit in pandemic response. It's also a benefit to going into developing countries where thermostability is an issue. We've heard a lot about new antigen production mechanisms where you can make antigen fast in response to a pandemic. Our adjuvant can be stockpiled as thermostable for years, can be extemporaneously mixed, and the data I'll show you is mixed at bedside. This can be done in factories as well. And it can be shipped at ambient temperatures, provides that thermostability to antigen, and allows for that self-administration, leading to early innate and late adaptive immune responses. I'll first talk about additional unique aspects of the platform, and then I'll apply those to influenza in particular. So the nano emulsion adjuvant is basically a nano emulsion droplet that's about 400 nanometers in size and is composed of CPC, surfactant, and oil. These are all components that are on the FDA list of inactive ingredients in approved drug products. And in and of itself, without antigen, the nano emulsion is anti-infective. We have phase 3 studies where if you put it on herpes labialis, you do as well as if you take a systemic antiviral. If you add an antigen, it provides the stability and the enhanced delivery to the immune system. This is what it looks like under EM. It's localized in the oil phase. Here you have a nano emulsion without antigen. Here you have a nano emulsion with 10 micrograms antigen-specific Fluzone, or strain-specific Fluzone. And the mechanism of action is that if you put the nano emulsion in the nose by drops, or at this point we're looking at sprays, the nano emulsion droplet is small enough that it gets in through hair follicles if you put it on the skin, and we think ciliated epithelium is important in the mucosa, and presents that antigen to dendritic cells via TLR2 and TLR4. I'll show you some of that data, and traffics it to local and systemic lymph nodes, leading to a better immune response that's both Th1 specific and improved antibody response. EMs of the mouse nasal epithelium on this slide at 7,900 or 2,600, 7,900x here. These are with nano emulsion, without nano emulsion. And you can see at higher magnification and with Q dots acting as a surrogate antigen, basically being taken up by the epithelial cells without disrupting the epithelial barrier. Green fluorescent protein without nanoemulsion and with nanoemulsion basically allows that loading of those epithelial cells, and at 24 hours, trafficking to those lymph nodes that I showed you in the diagram. Another way to look at this is using Q dots again as surrogate antigen. In mice that see Q dots with PBS without nanoemulsion, Q dots with nanoemulsion at 24 and 72 hours. And here you see the increased uptake in regional lymph nodes as well as the spleen at a later time point. I told you that the nanoemulsion helps enhance Th1, and here we also show Th17 specific cytokines. This is Hep B surface antigen, And if you compare to PBS, you see increased interferon gamma and TNF alpha cytokine responses, as well as IL-17 cytokine responses with nanoemulsion. The TLR2 and TLR4 that we heard about as well in one of the other products earlier today are important. As you see with PA and nanoemulsion, you have in wild-type mice high Th17 responses that are decreased if you have a TLR2 mutant and further decreased with a TLR4 mutant. And these are all higher than PA with alum, as well as nanoemulsion without antigen. The thermostability, in this case with Hep B surface antigen, is demonstrated in this slide. And here you have Silverstein and Western blots of Hep B surface antigen with nanoemulsion at 25 and 40 degrees. And you can see that the protein is kept intact. And here you have immunogenicity in mice and titers when you add Hep B surface antigen and nanoemulsion that have been basically kept at 4 degrees, 25 degrees, and 40 degrees for up to 6 weeks. And you can see that there's no depreciation in antibody response. And this, after 2 doses, this immune response is pretty stable and does not drop off as if you did not have adjuvant. So as applied to influenza, this slide shows stability with flu antigen. This is BPL inactivated flu vaccine in mice. And we haven't gone up to 40 degrees, but we went up to 25 degrees and up to 3 months. So here you see nanoemulsion alone and pre-immune mice. And this is post-infection in mice and HAI titers on the y-axis. So if you take the nanoemulsion with the BPL inactivated flu antigen at 1 day, 1 month, and 3 months, keeping it at 25 degrees does not make a difference in terms of HAI immunogenicity. In ferrets that we heard about as well, we get HAI titers that are quite high with 12 micrograms of strain-specific hemagglutinin, 7.5 micrograms, and even 2.5 micrograms that are higher than if you take 15 micrograms and administer them parenterally IM in ferrets. We are discussing as to why this is. I was picking the brain of the speaker that gave us the talk about ferrets, and ferrets are probably better designed to pick up antigen through their nasopharynx. Nonetheless, the fact that we see flu and other pathogens through our nasopharynx as well, we expect to see immune responses by that route of administration as well. This is true in ferrets here for both Fluvine, which is the Novartis off-the-shelf product, and Fluzone, which is the Sanofi off-the-shelf product. So we're just taking those products, administering to ferrets IM. These are naive ferrets, adding nanoemulsion and administering them IN at these different doses and getting these extremely high immune responses. We've heard a little bit about cross-protection, and I told you that mucosal administration may provide better cross-protection. Here we see vaccination in ferrets with A. Wisconsin and cross-reactivity with HAI to A. Wisconsin, and also cross-reactivity to A. California, A. New York, A. Wyoming, A. Wellington, A. Panama, with the 40 titer that's considered protective being depicted here. So if you compare the IM 15 micrograms versus the IN 2.5 micrograms with nanoemulsion, you can see that the nanoemulsion adjuvanted, intranasally administered lower dose of HA gives you better immune response and better cross-protective immune response that is above the seroprotective titers. In terms of the human clinical trial, we have performed one phase 1 study, and the paper's in process of being put together. It was a randomized, controlled, observer-blind, single-center study. The objective was mainly safety and tolerability. Secondary endpoints, immunogenicity by HAI. We added nasal wash IgA in the second part of the study. The arms were PBS intranasally as a control, Fluzone by itself intranasally. Everyone that got anything intranasally in this study, it was administered by drops. MB1008 is what we call the Fluzone that's off the shelf with our nanoemulsion, administered by drops at different doses that I'll show you in the next slide, as well as Fluzone administered IM. The schedule was one dose. Everybody only got vaccinated with one dose. And we monitored volunteers very carefully. They came back on day 2, 7, 28, 60 for immunogenicity, and then we called them at 180 and 365 to see how they're doing. The nano emulsion was a dose escalation, and we looked at 5, 10, 15, 20%. This is start here because it was in both part 1 and part 2 as a bridge. We looked at antigen dose of 4 micrograms and 10 micrograms of antigens or strain-specific HA. Total volume was 200 microliters if it was 4 micrograms and 500 microliters if it was 10 micrograms. We also looked at positioning at 45 degrees or having the subjects lie down. And I already talked about the immunogenicity endpoints. The safety data is summarized in this slide. And basically, you see the percent of volunteers with any of these symptoms, both local and systemic. Don't see much of a difference between PBS, ion Fluzone adjuvanted with any dose of nano emulsion. We do see a difference with IM Fluzone in that you're trading off local nasopharyngeal symptoms, regardless of what you put in the nasopharynx, whether it's PBS, Fluzone, or Fluzone with nano emulsion, for the pain that you get in the arm. Transient, mild and moderate, no major, no SAEs, no adverse events that resulted in discontinuation. There may be a little bit of a trend with sore throat. As the nano emulsion is administered by drops, we think that it flows down into the posterior nasopharynx and causes some throat pain and irritation, which isn't discussed here, or depicted here. So there's potentially some sensation that the volunteers are feeling as the product goes down the posterior nasopharynx. We hope to address that with nasal spray and covering more of the mucosal area, so we hope to get rid of this little bit of sore throat that, again, it's very short-lived and not a problem, but we could potentially get better immunogenicity and even less of this type of reactogenicity. In terms of HAI and our systemic immune responses, this is a little bit of a complex slide, but I'll walk you through it. Basically, you have HAI GMT, again on the y-axis, and you have a fair amount of pre-existing immunity. It's a seasonal vaccine. 4 micrograms versus 10 micrograms doesn't really matter in terms of what you're putting in the nose. As we start to add nano emulsion to the 4 micrograms, the low dose, still not much of a response. But as we add nano emulsion to the higher dose of 10 micrograms strain-specific HA, you can see that there's actually a dose response with our nano emulsion, 10%, 15%, and 20%, both the 45 and the supine group. And we think that you cover more of the area when you have folks lay down. And so you actually see statistically significantly better immune responses when you have folks lay down. We're planning to have them lay down as we administer the product by spray in the next clinical study. Actually, one other thing, again, HAI of 40 considered protective, and you bring everybody above that level. Also shown here, so if now on the y-axis you have a percent that are protected, and 70% being the goal, you're seeing that the adjuvant brings everybody across that threshold for all 3 influenza strains. In terms of nasal wash secretory IgA, here on this slide, you have HAI GMT again, except that since we're only looking at HAI to Fluzone, you have 0 and 28. So here we're seeing slightly different things. We don't see 3 different antigens like I showed you on the systemic immunogenicity, but you see 0 and 28. Not much of an increase in PBS. You see increases as you add Fluzone, and you see increases as you add Fluzone with nano emulsion. One important point here, we heard the last speaker talk about the difficulty measuring IgA, and we agree with that. One thing that I think is important to note is that we see an increase in total IgA, and this isn't just in the nasal washes. We see this in other studies, in stools of volunteers that received oral attenuated Shigella, for instance. So your total non-specific IgA goes up as well. If folks divide their antigen-specific by their total that has gone up, they lose their ability to detect that antigen-specific, the business end, the thing that's potentially protective. So I strongly advocate that if we're looking at mucosal immune responses, we look at the antigen-specific as well as the antigen-specific divided by the total. And this is antigen-specific only. If we divide it by the total, those immune responses go down. I told you I would show you some data that correlates mucosal immune responses with protection. This is not our data. This is data generated by the late Mary Lou Clemens from Hopkins. And I'd hope that everybody in this room has seen this data if we're talking about flu. What this does is take wild type or naturally infected folks, as well as folks that got parenterally administered TIV and nasally administered cold-adapted influenza vaccine. So these two are through the mucosal route. This one is parenteral. And basically divide those folks into those that shed or not shed and got sick or did not get sick after H1 or H1N1 or H3N2 challenge. Prior to that challenge, they took HAI GMTs and non-divided secretory IgA GMTs. They reported them as log 2 titers, so these are GMTs just for the sake of comparison. And the point of this slide is obviously to compare our product. Could this potentially be protective? So these are the immune responses that we get: 83 HAI GMT and 50 secretory IgA GMT. Wild-type infected folks that were not shedding, and again, they came in, they were, at some point in the past, they were infected with influenza. They did not have much of a serum immune response. They were walking around with a secretory IgA in nasal wash, and what differentiated them statistically, those that were not shedding and those that were not shedding influenza virus upon challenge had titers of 32. Those that did not get sick had titers of 40, very similar to the 40 that we point to in systemic immune response. In terms of those that were parenterally vaccinated, those that were not shedding had serum HAIs of 85, those that were shedding of 13, those that were not sick of 30, again in the same ballpark of the protective HAI that we all talk about, 30 or 40, and those that were sick had lower HAIs of 10. I will point out here that these folks had potential, or probably have seen natural influenza infection in the past, most likely through their mucosa. So they're boosting their immune responses at the mucosal level as well. However, in them it did not correlate with protection. And CAIV, as you might predict, is more similar to natural infection than parenteral vaccination. However, you need higher nasal wash IgA titers that correlate with lack of shedding, and there was no correlation with disease. It's important also to note that, as with FluMist, and somebody asked about FluMist, comparing yourself to FluMist, we all know that FluMist generates very low HAI GMT. So you vaccinate with a product that works mucosally, don't expect to get high HAIs systemically. That's why FluMist had to show protection. I'll end by saying that we think that our current data suggests that nanoemulsion mucosal adjuvant is safe and well tolerated, administered IN in up to 140 volunteers who got it intranasally, provides thermostability to influenza antigen, and facilitates a robust immune response to an activated antigen that's mucosal as well as systemic, with a Th1 component as well as a Th17 component, and generates cross-protective immune responses. Future directions, as I've already alluded to, we're looking to optimize the dose of antigen. We'd like to look at standard 15 micrograms of HA. We've only gone up to 10, and we can do that with high-dose Fluzone, optimize delivery via the sprayer, expand to other antigens. We're going to look at cell-based antigens, plant-based antigens, as well as other mucosal viral and bacterial pathogens. I'd like to thank the volunteers of the clinical study, as well as the folks at the University of Michigan, and folks at NanoBio, as well as you, the audience. Thank you.
Thank you very much for that overview. Are there any questions from the audience? Yes, Nick.
So just two things. The first was, in the clinical trial you had an intramuscular control, but you didn't show the data, so I'd be interested to know how relatively...
Yeah, no, good question. The serum HAI is higher, okay? As we all know what it is. It's hundreds, okay? Whereas the nasal wash IgA is in the low hundreds, 80 to 100, not 500, 600, 700. One of the reasons we don't show it is there were 5 volunteers. They were a control, that was thrown in. It wasn't necessarily the greatest control group, not well powered. I would have probably preferred to have seen a flu mist control group, personally.
And the second question was the longevity of the response. So I guess people talk about the mucosal response falling away much more rapidly than the parenteral response.
No,
Do you have any data?
Yeah, absolutely. I appreciate that. Just much as we saw in the last talk, we see that at day 60, the systemic immune response continues to climb, actually. So, whereas the IgA drops off. So we didn't look at IgA probably at the optimal time point. Next, in this upcoming study, we're going to look at day 14 and 28. In the study that I just showed you, we looked at 28 and 60, and I showed you the 28 results. The IgA goes up at 28, drops off, whereas the HAI systemic continues to rise. Thank you.
Any other questions? Okay, then I would like to
Okay, thank you.
introduce